Hello, good morning everyone. This is Dr. Sindhu, second year PGT from COM JNM Hospital, Kalyani. Today my seminar topic will be cutaneous adverse drug reaction. So what is cutaneous adverse drug reaction? By definition, any harmful response to unintended drug use that can occur at the doses normally used in humans for the prophylaxis, diagnosis or treatment of the disease. And what is severe cutaneous adverse drug reaction? Life-threatening either in the form of death or if it requires prolonged hospital stay or resulting in disability, then it is called as severe cutaneous adverse drug reaction. And the list of severe cutaneous adverse drug reactions are anaphylaxis, anticoagulant-induced skin necrosis, acute generalized exanthematous pustulosis, drugs, also known as drug-induced hypersensitivity syndrome, generalized bullous FDE, Stevens-Johnson and 10, and clotrimazole-associated sudden conjunctivitis, lymphopenia, rash with hemodynamic changes. So my first case would be 32-year male presented with sudden onset erosions with crusting and bleeding on lips since 2 days. History of cefixime 400 mg intake present 1 day prior to onset of lesion for his fever. Previous history of similar episode present 1 year back in which lesions appear at the same time. No other significant history has been elicited. Naranjo scale was 8 points, that means probable, and Hartwig scale showed level 3, that requires treatment and stoppage of offending drug. So this is the picture showing erythematous erosions and crusting. So the diagnosis would be fixed drug eruption. Clinical features will be erythematous, dusky red, oval to round macules to plaques. Gender-dependent pattern of distribution will be seen in FDE. Women's on hand and feet and men on genitalia. On readmission, lesions would occur at the same site. Onset of the lesion features would be during first episode, it would take few days to few weeks. Subsequent episode can occur even less than 24 hours. Variants will be bullous FDE, generalized bullous FDE, erythematous edematous plaques, linear FDE. Histopathological findings will be lycanode infiltrate composed of lymphocyte admixed with eosinophils and scattered keratinocyte in epidermis. And my second case would be 15 years old boy Noor presented with high-grade fever followed by sudden onset pustular lesions all over body since 3 days. Pustules started from intertriginous area, then spread to cover entire body within few hours. On examination, generalized non-follicular pustules on erythematous edematous base was found. No history of previous skin disease was present. History of terbinafine intake 1 day prior to rash was there. Naranjo scale was 8, that is probable. Hartwig scale was level 4, that was requiring admission stoppage of drug. So here is the picture showing predominantly non-follicular pustules on erythematous base distributed generalized. And the diagnosis would be acute generalized exanthematous pustulosis. Clinical feature would be high fever, lesions beginning on the face or in major intertriginous areas, axilla and groin, followed by dissemination over few hours. Numerous small, less than 5 mm, primarily non-follicular pustules arise within large erythematous base. Marked leukocytes with elevated neutrophil count would be present. And the differential diagnosis can be acute pustular psoriasis of von Zumbusch type that can be differentiated by absent history of psoriasis, rapid appearance, and recent drug exposure. All this favor will be aging. Pustules of the drug should be differentiated, which are characterized by facial edema, prolonged evolution of lesions, atypical lymphocytosis, marked hypereosinophilia, and common visceral involvement usually permit differentiation, which are predominant in drugs. Common drugs causing AGEP are penicillin, cephalosporin, clindamycin, pristinamycin, terbinafine, diltiazem. And histopathological findings will be subcorneal pustules composed of neutrophils as well as scattered neutrophils in epidermis. My case 3 would be a 35-year female Rani, known case of tuberculosis on anti-Koch treatment, presented with sudden onset erythematous generalized maculopapular rash since 2 days. Patient has started AKT 2 months back. On examination, there was facial edema, lymphadenopathy, LFT was deranged, and CBC showed leukocytosis with eosinophilia. And here is the picture of it. And diagnosis would be drug reaction with eosinophilia and systemic symptoms. It is also known as drug-induced hypersensitivity syndrome or drug-induced delayed multi-organ hypersensitivity syndrome. And diagnostic criteria of DRUS will be REGIS-scar, J-scar. Typically, all 7 typical DRUS will have all 7 features in it, and atypical DIS will obey only 5 among them. And variants of age variants would be of DRUS or AGEP like, EM like, purpuric. Edema of the face will be hallmark. Multiple organs involvement would be present in the form of lymphadenopathy, hepatitis, interstitial nephritis, myocarditis, interstitial pneumonitis, myositis, thyroiditis, even infiltration of the brain by eosinophils. Can progress to hemophagocytic lymphohistiocytosis. Common drugs causing are carbamazepine, lamotrigine, phenobarbital, phenytoin, dapsone, minocycline, trimethoprim, sulfamethoxazole, vancomycin, abacavir, nevirapine, and albuterol. My case 4 would be 10-year-old Pranav presented with widespread bullous, erythematic pruritic eruption, bilateral conjunctivitis, edema of lips and eyelids, hemorrhagic crust on the lips, superficial erosion of hard palate, and ulceration of penile meter since 2 days. The symptoms started approximately 7 hours after intramuscular administration of second dose of cefazolin for pharyngitis. The picture is showing dusty erythematous plaques with few vesiculobullous lesions on the trunk and upper limb and erosion on the face and glands. And the diagnosis will be Stevens-Johnson. Epidermal detachment is less than 10% body surface area, and the drugs that can cause Stevens-Johnson are allopurinol, NSAIDs, antibiotics, and aromatic anticonvulsant. Onset will be 7 to 21 days of drug intake. Clinical features will be erythematous, dusky red or purpuric macules of irregular size and shape. They have tendency to coalesce. We can also elicit Nikolsky sign, which would be false positive. Then it can progress to vesiculobullous lesion, giving Asbjörnsen sign. And then wet cigarette paper like shedding of skin will be present, that is known as scalding. In this patient, score 10 was 1 on the day of admission, which only criteria fulfilled were heart rate greater than 180. Prognostic scoring system of 10 would be score 10, ABCD 10, Alden. Score 10 include following prognostic criteria: age greater than 40, heart rate greater than 120, cancer or hematological malignancy, body surface area on day 10 is greater than 10, serum urea greater than 10 millimole per liter, serum bicarbonate less than 20 millimole per liter, serum glucose greater than 14 millimoles per liter. Diagnosis. How to diagnose a adverse drug reaction? Depending on clinical features, primary lesion, either it can be, depending on the primary lesion we can diagnose. One is, it can be urticarial or erythematous papule, pustule, purpuric papule, vesicle, bulla, mucous membrane involvement, fever, pruritus, lymph node enlargement, and facial edema. And time interval is very important. Chronology of the lesions. Exanthematous eruption would take 4 to 14 days, and urticaria will take minutes to hour, and phalanxis also will take minutes to hour. Fixed drug eruption will take, on the first exposure it will take 1 to 2 weeks. Re-exposure will take less than 2 days. AGEP will take less than 4 days. DRUS will take 15 to 40 days, and SJSN 10 will take 7 to 21 days. Other diagnostic aids of minimal significance is IgE assay, histamine release test, migration inhibition factor test, lymphocyte toxicity assay, lymphocyte transformation test, basophil degranulation test, patch test, and prick test. Thank you.